Is now starting. All attendees are in listen-only mode.
All right, Rich. Good evening. How are you doing, buddy?
Good evening, Guy. I'm doing well, thank you. Nice
Good.
and warm here in South Texas. You staying dry in Florida?
It got some rain, but that's the summer. It's all good. And I officially started the webinar, so we won't forget to do that one again after we did that a few webinars ago. And I know this is the most exciting subject for everyone on a Tuesday night. They're sitting on the edge of their seat going, I am so excited to spend my evening talking about Medicare. But, you know, it can be exciting. And we have some a pretty important information that's right off the presses that we'll get into towards the end about same and similar. So I like Medicare, Rich, and I think you do too. And I think the biggest thing is people are afraid of it. I mean, when I give lectures, and you gave a lecture in the Florida Dental Convention last weekend, right?
I did.
When you bring up Medicare, this is usually the reaction I see. That immediately they go, oh no, I don't want anything to do with Medicare. Did anybody do that last weekend when you brought it up?
I was actually teaching a workshop, Guy, where we were delivering dental devices on each other, and you know, every time you get a lull in it, somebody go, hey, what about Medicare? You know, I live in Florida here, and half our patients, half the year, are Medicare patients. You know, and it seems to be that people either embrace it and do really well with it, or they stick their head in the sand, you know, and they just don't learn about it. So they're kind of that back off approach. And we obviously want you to not do that. I think there's a lot of reasons that this is important, but we'll get to some of those as we go along.
Yeah, and I think one of the reasons I think people get that way, Rich, is I think they confuse it with Medicaid. Medicaid, state welfare, it's for, you know, it's a whole different thing. Medicare is what part of every one of our checks go to every month, and all your employees, and you pay for part of it for your employees, and it's basically federal health insured for the retired or disabled. And so one day you're going to need Medicare benefits, and as Rich and I talked about over the last few years, we're getting closer to that age, and so we're starting to realize this is going to be a benefit, and it's the right thing to do. People work their whole lives, they've paid money into this program, and if we can help them extract some money out of that program that they paid all their lives into, well, then we're not only helping them with their airway, we're helping them with their finances, and it's really just the right thing to do. So don't confuse this with Medicaid. And I tell you, Rich, you know, we see fee-for-service patients, we see commercial insurance, we see a lot of Medicare here in Florida. It's a high percentage of Medicare, and I can tell you we make money on them. And as well as helping them. So not being afraid is important, but also dental sleep, just getting involved. I know we have kind of the gamut of people on these webinars, and by the way, you can go and type questions into the question box, and we have a whole team of people answering them. Rich and I will answer. We'll make sure we get to all those before the webinar's over. But you know, dentistry's gone down over the last few years, and as far as what dentists are making. If you look at this from Dr. Bicuspid, 2010, $88 an hour we were averaging in our dental chairs, down in 2016 to below 60. I mean, that's a pretty big difference. And then if you look at the net income of dentists back in 2005, over 200K, 215, and here we are at 2013, down 16%, you know, from over 200 to, you know, notably under 200. And I know we sound like broken records to some of you, but we also have a lot of people I see on, I know we had several hundred register for this webinar tonight, and a lot of the people that we help each day do this in their office, they can attest you can make money doing this. If you do as little as a device a month, you can add another $19,000 in income. And if you do one a week and take 4 weeks off a year, you're pushing 6 figures you're adding to your what you're making in your office while you're helping your patients live. And I don't think, Rich, that we're exaggerating anything with these figures, are you?
No, absolutely not. Go back one slide there, Guy, because
Sure.
What was it? You know, it's down to 180 in 13, so I'm guessing it's not too far off that number. And when you go forward one and you're looking at, you know, basically one dental device a week after you pay for DS3 and your third-party biller to help you bill, which we absolutely recommend that you do that. You've almost, you know, you've given your income a 50% boost there, Guy. So
Yeah.
that's, I don't know any other way to do that.
No, it's if you'll use the systems we'll help you with, and through these webinars, through our services, this is very, very, very obtainable to do 4 devices a month. I mean, you've got to almost not be trying. So these numbers are very conservative, and I just think this is the right thing to do, is to get involved in this in your offices. I mean, at least treating your patients that need your help. It'll make your restorative practices better. And I know we're talking about Medicare here tonight, but getting involved in dental sleep in general is a fantastic thing to do, and it's even more fun when you get paid for it. So that's what we're going to talk about today. So there we are, Rich. We've been friends for quite a long time. I was thinking about this the other day. I was got some new team members on board, and we're talking about how I came to be involved in dental sleep. And I actually called you just before this webinar, and it came up on my phone, mentor, AADSM. It's still the way it's labeled, because I met Rich a dozen or more years ago as my mentor in the American Academy of Dental Sleep Medicine. And between what he knew and some systems that we've put together, we've learned how to do this pretty effectively and done thousands of devices between us now. And I'm glad we met. At times I wondered, but all the time it's taken out of our lives. But I think we can help you all learn how to do this well as well. And you will get CE for this. So within 72 hours, it's going to go to you. If you don't see it before you contact us, we'd love for you to contact us, but for other reasons, look in your junk folder, and you'll find the CE there for you. Rich, they're going to give us another week off here in a few weeks.
Yeah, fantastic. We Guy and I do these, we do these, and we do our online study clubs, about pretty much about every other week. So just about every week we're doing these. So Jason and who's that good looking one? Yeah, Dr. Elliott. So they're going to talk about, some things that you shouldn't do. I think tonight, Guy, we're going to talk about one of the things you should do, with the Medicare. So.
Yeah. Yeah, and I think knowing what not to do is just as important as knowing what to. And I've heard Dr. Elliott speak many times. She's spoken at our symposium the last few years, and Jason, of course, is just a huge knowledge in dental sleep, and you'll learn a lot from this. And Rich, we'll get the week off, so fantastic. People always ask, what do you do? I actually saw someone today, was my former dental patient. She's a realtor, and she was like, well, aren't you retired? What are you doing now? No, what I do is what we do every day, and we get up and go to the office now. We help dentists who want to succeed in dental sleep. That's why we exist. That's what I get up every morning going to do, and why Rich and I formed this company with the help of a bunch of other people. So in a nutshell, we have a 360 degrees of full, complete solution to helping dentists get involved in dental sleep. And we'll put up more information at the end. If you want to know how we can help you, just type in consultation at any time tonight. We'll meet with you. We'll have our experts talk to you, and you'll get some free advice at the very least, and see what we can do to help with your dental sleep challenges. Because if you've got a specific question, we have people that can answer it for you. Rich, did you get your article done for this?
I did. I got it done Sunday morning. I woke up early and got mine done. So, we do a lot of stuff for free, don't we, Guy?
Yes.
We help dentists do this, and we want you to be a part of the DS3 system and what we do. But we dangle that carrot out there with a lot of really good information that doesn't cost you anything. So dentalsleepinsider.com, you can sign up. It doesn't cost you anything. Every single month, I think, what are we on, Guy number 25 or 26, something like that?
Something like that. Yeah, we've got the covers lining the halls of the DS3 corporate office, and we're going to need a longer haul before too long. So it's great information. Still sign up. We have people, over 90,000 people will receive those. Just a lot of the people like you all that are on this webinar, and we thank you all for taking the time tonight too to be here. We have people from all over, all the way from here to Japan, listening in usually on these things tonight. So let's talk about insurance, Rich. In general, is this that's the way your office feels?
That's right, man. I mean, if you go to a dental sleep course and you come back, they're like, oh my gosh, what do we have to do now? And I think you have to ask yourself, are you really trained to do that part of it? I mean, you are trained to do root canals and look at x-rays and implants and, that kind of stuff. But how about I booked my flight, Guy, for Florida, I wonder what I'd do if I got on and I saw you in the front there smiling. Hey, what a minute.
Yeah, I mean, you wouldn't be that comfortable because I don't know how to fly a plane, and even if I tried to learn, I wouldn't be as good as this guy. And I think our take-home message is you could do all these things if you want. You can, most of us could do whatever we put our minds to. We could do our own taxes, fly our planes, do our own plumbing, but it's going to be a lot harder for us to do. We're not going to do it as well. It's going to take us longer, and we're probably going to learn the hard way. And our take-home message when it comes to billing, and we're going to talk about Medicare specifically right after the slide, is to use a company that's all they do. And towards the end, we're going to talk about just a change that's just happened in the last few weeks, last month or so. And if you're doing this on your own, you're not going to find that out until it costs you a bunch of money. Use a company like 4-Pillar Billing or Pristine Billing, GoGo Billing, one of these third-party billing companies that just do dental sleep, and we can prevent a lot of headaches. And so if you want to just prevent a lot, that's how you're going to do it. So all right, Medicare, that's what we promised to talk about, and so we're going to get into the nitty-gritty on it. This is the way Medicare's been for as long as I know, Rich. About they pay the 80% and 20, and this E0486 has been out how long now? Maybe they've been paying for 8 or 10 years.
Yeah, but that's the good news. I mean, I think there's some guy that there are a couple in Florida when I did that course this weekend, and they were like, I did this a dozen or so years ago. I did a few, and you couldn't get paid, and it's like, man, I think maybe now it's time to revisit it. So I think we're getting a lot of dentists that went around the first time and had kind of a bad taste in their mouth, because we didn't have codes and we didn't have a lot of this stuff, and now we do have codes. So, when you look at Medicare patients and the people that come in, we're going to go through all the different jurisdictions and all this stuff, but there is a fee there. There is an allowable. We know what that is. We can make a choice on whether we participate or non-participate, can balance bill or not. So we're going to break it down into little tiny bite-sized chunks of this so that you'll understand it. Sometime, Guy, we ought to get out the calculator and find out how many people are in each jurisdiction. It's kind of funny that the Northeast, where most of the laws are made in the country and everything, is the smallest area and they pay the most. I don't know if anybody else finds that ironic, but
yeah. So to explain this slide, if you're practicing in one of these states, they allow $1,814.98, and that can change by a few dollars, and it can change with time. But yet another reason to use a third-party biller, because you'll know when that fee changes much quicker than if you try to figure it out on your own. So that's what they allow. 80% of that is what Medicare will actually pay, and then the patient is responsible for 20%. So the patient was 363 of that. But now the good news is most patients across the country in all jurisdictions, the vast majority of them have supplemental insurance that actually picks up that 20%, in this case 363. So that's jurisdiction A, that's the allowable amount. So essentially you're leaving $1,422 on the table that the patient could be tapped into, and in most cases it's $1,800 you're leaving on the table because they have the supplemental insurance. Jurisdiction B, I'll just leave this up here, same thing. The allowable is the big number at the top, and then you have your 80 and 20% there, where the Medicare pays the 80, which is $1,062, and then the patient pays the $270.97. But again, in most cases, they have supplemental that covers that. And then here we are in the great South that Rich and I live in with the lowest amount. And we still believe this is worthwhile doing, even though somehow we got the short straw and got the lowest paid region at $1,070 roughly. And then the last region, jurisdiction D, and here's your figures. I'll leave them up there for a second. Anything more on those fees or the jurisdictions, Rich?
No, if you're in the high one, good for you. If you're not, like you said, we want to try to teach you how to be efficient at this and how to pick and choose what you do so that you can not only maximize what the patient gets out of this, but what we get out of this as a dentist as well.
And we're going to show you in just a moment too. Don't get off the webinar now because you think I can't do this for $1,070. You can get more than that. The patient can take that amount of money and that they can pay you in addition to that, which we're going to show you in just a few moments. So don't let that run you off just yet. These are the decisions that you have to make. I think one thing that comes up too, Rich, when we teach these courses is they go, well, I haven't really done anything with Medicare. Why do I have to do it now? And the reason you have to do something once you start treating treating obstructive sleep apnea patients with mandibular advancement devices, it's because now you're doing a service that's covered by Medicare. Dental procedures aren't. And so once you start doing these procedures, you're treating apnea patients with mandibular advancement devices, then you need to make a decision on Medicare. And there's really 3 choices that we'll go through with you. Had anybody opted out then your course you taught last weekend, Rich? Yet, or did you know?
No, and then that was probably a good thing, because when you do, it's 2-year contract, and you got to remember that. So there's certainly nothing wrong with doing this, but it's one of the 3 options that we have. But you got to remember that when you sign that contract, and it's just 2 pages long, I think, Guy, I can't bill Medicare, and the patient can't bill Medicare. So we are basically opting completely out of that system, so that neither one of us is going to take advantage of that. And if I were a Medicare patient, how would I feel about you, Guy, if you opted out?
Yeah.
I might be okay if I got $20 million in the bank, but anything less than that, I might think, well, I want to take advantage of my insurance. So some of you may live in areas where you don't have any people over 65 years old. I don't know, but again, this is one of the options. It's not the one that we recommend, but if you decide you want to do it, this is how you do it. Like Guy said, you got to pick one of these 3. So
right. And so the other is you can become a Medicare provider. And, it takes time to do this, and we're going to kind of walk you through some of the steps of doing this in just a little bit. You've got to submit the claims once you do this, and you have to adhere to the Medicare guidelines that we're going to go through with you in just a few moments. There's 2 ways of becoming a Medicare provider. One is you participate, and the other is you become a non-participating Medicare provider. So you fill out this application differently depending on how you want to set yourself up. Participating will be that you really have to accept the Medicare allowable amount on all cases, and the checks will come to you. And so we don't recommend you doing that, and you're going to understand why in just a moment. We recommend, as you can see, it's a little bolder, a little highlighted here, we recommend that you become a non-participating Medicare provider. And the reason we recommend you doing that is because you can, there's a little place on the form that you fill out. What boxes? I think, Rich, you know the
27
box.
On the CMS 1500 claim form, box 27.
Right. Box 27, you don't check accept assignment of benefits. And what that means, if you're a non-participating provider, that means the checks are going to go to the patient. So if you live here in Florida, they're going to get $1,070 between their Medicare and their supplemental amount. But you can bill your patient your normal fee if it happens to be more than $1,070. So they're basically just getting money put towards their treatment. If you wanted to be a participating provider, you can do that on any given case. And so because you're a non-participating provider, you can go ahead and check that accept assignment of benefits in box 27. Now on that case, it's just like you being a participating provider. And so now the checks are all going to come to you, but you can't balance bill the patient. So you have to accept whatever that allowable amount is in your area. So again, participating or non-participating, if you choose non-participating, you can swap over to participating at any time that you want to on a case-by-case basis. So we have a strong bias that you either opt out or you become a non-participating provider. There's really no benefit to becoming a participating provider, because if you want to participate, you can do it on every single case if you decided to. Did I miss anything on that, Richard? That's oftentimes confusing.
I think that's good. Just remember, that in one instance, the checks come to me when I participate, but when I don't participate, they go to the patient. Right. So you got to know that up front. You got to make sure that the patient understands that. And if you don't collect that money from them, then you got to chase that check down. And
right. But the advantage is you can bill them more if they allow, if your jurisdiction doesn't pay you enough to make you happy to do this. So
some of the secondaries pay quite a bit, Guy. We've learned over the years. So this if you really start to work this, I'm not saying work it, but I mean the rules are the rules. We're playing by the rules.
Right.
And by the way, it is June 26, 2018,
yes.
because the rules might change next week. So
right.
we record these things, and if you're listening to this at a later date, please make sure that you check and make sure that that the information is still current.
Yeah, absolutely. So again, non-participating is what a recommendation is, and then you can go back and forth. And I just want to hammer it home because I even see some questions coming up on the screen about it. If you check accept assignment of benefits, then all the checks are going to come to you, but you will not and cannot get more than the allowed amount in your particular jurisdiction, one of those 4 we went through previously. If you don't check assignment of benefits and you're non-participating, the checks are going to go to the patient, but you can bill your normal fee and expect them to pay up to whatever your normal fee is. So the patient is going to basically get reimbursed. And as Rich mentioned, sometimes they get reimbursed the full amount with certain supplemental insurances. So our reason for saying to do non-participating, the patient's going to get money back to them. And why not reduce their overall costs by just going through the procedures we're going to show you how to do right now.
One of which is you got to become a DME supplier. So this is the Medicare thing. This, I think, is one of those things, Guy, where people go, oh, no, So, yeah, there's an application process. You can do it online through the PICO system. We recommend that you pay somebody to do this. It doesn't cost that much money. We have third-party billers from 4Pillar and Pristine and GoGo, and we work with a lot of these people, and they all do a good job. And it costs a little bit of money. They charge you a little bit of money to do it, but they're going to make that process simpler and easier. So it's not that bad. You just download the form, or you do it online. You work with a third-party biller to do it, and pay your money, take your licks, and next thing you know, you got it, and you're on your way.
Yeah, well, a couple of points on this slide. $560 is the current fee, as far as I know, that you have to pay Medicare. That's not for the third-party billers to help you. So that money, you have to write a check to them. And what I've highlighted down here is 27 pages long. And what we find is most of the time people screw this up. If they do it on their own, then it gets kicked back. And I know that we work a lot with one of our co-companies, 4Pillar Billing, and they've got this down to getting most people's Medicare within a few months' time. And you know what? If you think about that, you pay them their fee to do this, which is around $1,000 for our members. You do one device, and if you waited 4 months to do it, how many devices could you have done that you're missing out on because it took you that long to do it? So this is something, if you're going to be doing dental sleep and you want to get involved in Medicare, get going on this as soon as possible, because you're going to have patients coming in who need this. So once part of the process is they're going to come visit your office, which totally, I know now you all are really ready not to do this. The moment you hear some government officials going to come to your office, no, I'm out. I don't want to do it. But this is probably the easiest thing that's ever, any kind of inspection I've ever had in my life.
I was in with a consultation guy with a patient.
Yeah.
And I came out and somebody goes, hey, the Medicare people were just here. What? Yeah, they took a couple of pictures and we showed them a couple of forms and they left. It was like, That was it. It wasn't any big deal.
Yeah, the only thing they seem to be sticklers on is you got to have your hours posted on the outside of the door. And even if you don't, they're going to tell you to do it, take a picture and send it to them. Another reason to use your third-party billers, they will make sure you're prepared for this visit. They'll give you the checklist of stuff. Don't let this be a reason to scare you away. They won't be there more than 30 minutes, 20 minutes. It's a really easy thing, especially if you're prepared, but they will come by. And then you need to have certain things ready for them and for all your patients. That they want you to have like a little folder or something that has certain items. And one of them is home care instructions. If we have ours here, you can make your own. I think those are pretty self-explanatory. And whether you're doing Medicare or not, you need to have these. It's something you're going to be going through with your patients. And then you got to have the supplier standards, and it's just something that your third-party billers can give you. I haven't looked at that in a long time. I don't even remember exactly what all's in there. Do you, Rich?
I don't even know what you're talking about, guys.
We've
got it. Like you said, once you get all this stuff, you just kind of stick it over there in the corner so you've got it. Now we do use that patient home care. We use that every single time we deliver a device. The rest of this stuff is just a checklist. You gotta do it. It's not that bad. So just suck it up and do it.
Yep. I see questions coming through, and I think our team's answering them great. So keep them coming. We will answer them all through the question portal, or we will answer them verbally or both. So we're happy to stay on when we're finished as long as needed. You've got to have an equipment warranty form. You can see it here. This is recorded. You can come back and look at it again and copy down what we have there. But you just got to have some sort of a plan with that. And again, we have all this in a folder. It's been so long since I've looked at it that I'm not even familiar with what it says in there. If a patient isn't happy with you, there has to be a method for you to document that, and this is just something Medicare procedures they want you to have, and you need a complaint log, which I think we have one complaint in 8 years in our log. I don't know about you, but it's not something to scare you away either, and just names and phone numbers and any incidences that you may have. This protocols, Rich, I'm sure you have that in there too.
Yeah, I think really, Guy, most of this stuff is reasonable. When you think about, in your practice, you would, as a patient walking into some place, I'd certainly want to have what my home care instructions are, the hours, when they're open, when they're not open, the a way to file a complaint and resolve it and all that kind of stuff. It all makes sense, and it's all reasonable, I think.
Yeah. So, and again, none of this is scary. If you have more questions about this, because I don't want to focus too much on the paperwork there, we want to get into a little more of the procedures in just a second. Again, feel free to type in consultation. One of our experts will get with you, answer your questions, tell you how we can help you in the future. We routinely get people just telling us how beneficial the phone call, the time that we spent with them to answer the questions are before even becoming a DS3 member. So feel free to type that in, and someone will clarify any of this that we're going a little too quick for. And it can be about non-Medicare issues as well. One thing we have to do, Rich, once we get our Medicare license number, whatever you want to call it, we have to make sure we follow their guidelines. And I think the biggest one for us that affects our clinical time is we have to use one of the devices that Medicare has approved. And I don't know if they have a rhyme or reason for this to say sometimes. I wouldn't say these are the only good devices out there, but there are good devices. And the good news is you got two pretty good choices here to do. I think between most of these, I don't know that I've ever seen a patient that one of these two, between the two of them, that this is just the wrong device. It's rare, if ever. Do you agree with that,
Yeah.
Rich?
And that list is growing. Medicare has their rules with all this kind of stuff, and the devices have to be hooked together and they can't come apart. And there's all these other things, and that list is growing, every week. So again, we want to check back. We'll work on getting the link on this as well for where you can find those things and that kind of stuff. But clinically, I think a lot of us as a dentist, Guy, we're like, which device do I make? I mean, we know, even it's not a Medicare patient, we know most of the dentists go, well, which device do I make which patient? Well, with Medicare, you could just flip a coin. You don't have 100 choices. You just have a couple. So we're happy to speak with you guys about that. This is just part of that process as you get into this and you do it where you have 1,000 questions, and that's what we do to help you. So there's your choices for now. We just move on. There are other guidelines that we have to follow as we look at Medicare and what we do. And those are the things that, we're just kind of walking you through these steps right now.
Yeah, let me just emphasize, Rich, because that this is one of the TAPs, and these are the HERPS types devices. And so if you want to know more about that, then tune into one of our whole webinars on devices. But the TAP or the HERPS type devices are what we commonly do. And in most cases, one of those two is certainly a suitable device for most patients out there, between the two of them. And then here's the specific guidelines they have. What'd you say a minute ago, that it's not unreasonable? I think, as much as the government sometimes we think is unreasonable, a lot of what they've done here, I think makes sense to me.
It does. We could argue the MD face-to-face, like that, because I think we're in a good place as a dentist to see patients, to see airways, to see that. But, if you're screening your patients and this guy's falling asleep, while you're giving him a shot, I used to think that was because I was a good dentist guy. You know, I didn't realize the guy had sleep apnea, he was about to die, you know. Right. But, you know, they got to have that face-to-face with the MD. If you're in a remote area, telemedicine does qualify in certain instances for that face-to-face. But just remember that when you have a Medicare patient in your office and you've screened them and they need to get a sleep test, they have to see their MD. Mm-hmm. And then once the MD says, okay, it's necessary to do the sleep test, the MD orders the sleep test, and then the sleep study, they have to meet certain criteria. So remember, with mild, moderate, and severe sleep apnea, those numbers are 5 to 15, 15 to 30, and greater than 30. I always tell people, Guy, how you remember that's 10, 20, 30, you know, for mild, moderate, and severe. So you got to remember that for mild sleep apnea, the patient has to have had a minimum number of events. In this case, for mild, it's 10 events. And then you have to document some of the comorbidities of sleep apnea, which is not hard because they're snore, they're sleepy during the day, mentation issues. I can't remember things. Most Medicare patients, that's probably true, Guy, right? They can't remember certain things. You see the mood disorders, insomnia, high blood pressure, reflux disease, stroke. You know, all of these things count as some of those comorbidities.
You just have to have one, to be clear.
Yes, right. Now, when you jump up to moderate sleep apnea, they have to have a minimum of 30 events, but we don't have to have any of that other stuff documented. And then when we jump up to severe sleep apnea, then we basically have to have something from the patient that says, I tried CPAP and I failed, or there's just no way I can do that, or it's contraindicated for some reason. And on top of that, Guy, we get into the same and similar. So we're going to talk about that later in the program tonight.
Yeah, so that's something that's kind of changed. Well, it hasn't kind of, it has changed over the last month or so. So I kind of put it towards the end because it's the first time we've actually talked about it. We'll be talking about it in just a little while. Let me
add one thing to that, Guy. Remember that, you know, go back one, the device is then prescribed by the physician. Mm-hmm. Okay, so we get that prescription. And then, interestingly, you know, Medicare says a dentist has to do this. Right. Now, we are hearing more and more about physicians doing this in different parts around the country. I don't think that's a good idea. But at any point, there aren't very many of them doing it, thank goodness. And then we already talked about the approved, Medicare-approved devices. Mm-hmm. Is that okay, Guy? That simple about the mild, moderate, and severe? You have to have a certain number of events, and then you have to have basically the more mild the disease, you have to have comorbidities. The more severe, you don't need them, and you have to throw in the CPAP stuff.
Right, and I don't know that, you know, the only thing I would say, just to not split hairs here, it's not often that you're going to have an AHI of 15 without 30 events because they're not going to accept the sleep study unless they slept for 4 or 5 hours. So right. That's almost a non-issue in many cases. So I don't really even pay much attention to that. Really, if they're mild, they have to have comorbidities. If they're severe, they've got to have a reason they can't wear CPAP. And then if they're moderate, you're golden. Other than same and similar, which we're going to talk about in just a few minutes. So they have to have a diagnosis of apnea too. If they have upper airway resistance syndrome, then you know it's got to be right. And actually, it has to be obstructive sleep apnea. I just said apnea. It has to be obstructive sleep apnea. G4733 is the diagnosis code they must have. And then the treatment code is the E0486. That's what we you bill it. And again, this is Greek to you. That's why you use your third-party billers. And then you put your modifiers in, which means that you're adherent to the standards that we're going to be going through, and that it's a new device. And they will pay for this about every 5 years. If the device is durable medical equipment, it's not permanent medical equipment, it's going to wear out. And the good news is Medicare will pay for that again, and they'll pay you or the patient for that every 5 years. And in certain circumstances, they'll pay it even more often than that. There is something like a stolen or so forth. That we've seen coverage on that as well.
But not wear and tear.
Not wear and tear, right? Yes. So they're better off lost it than to have broken it, just because they chewed on it too hard. We'll leave it at that. See, the CPAP affidavit, they basically have to have tried CPAP or say why they can't wear it. A letter from the physician works. I mean, I've seen that more and more, Rich, where there's really a reason why CPAP's not indicated for a patient. And, I think we always think they have to try it, and that's not true. The physician has to say it's contraindicated for this reason. That works in lieu of this. I've tried CPAP, and I can't wear it for these reasons, which is what the CPAP affidavit is. They have to have a written prescription that says right there in the standards that, they have to order it. Here's what we include on ours. Who does this, Rich?
Usually we call it the best MD guy, because sometimes it's a primary care doc, sometimes it's a cardiologist, sometimes it's a sleep doc, and we just say, Guy Yatros, I'm prescribing a mandibular repositioning device for this patient, for these reasons, for documented sleep apnea. It's a custom dental device. It's needed for lifetime, and it's medically necessary. So then we keep that on file, and we have to have that. In our system with DS3, it's real easy because we just scan it, and we've got a digital copy of it in there.
Right. And by the way, make sure we've made that clear. We can write this out and send it to the physician, just ask them to sign it and send it back. But the physician has to sign this, and as their primary care or the main treating physician is the best one to sign this. Now, can the guy that reads the sleep test sign this? And some insurance policies allow that. So, yeah, in some cases, but you can't go wrong with the treating physician signing it. Even some companies like sleeptest.com will provide these for you when you get a home sleep test as a dentist order, and that'll work in many cases. So, but again, if you want to be best practices and do things as well as possible, communicating with whoever's treating that patient, you can't go wrong legally, and also it can't go wrong with treating the patient right. I mean, I think we should communicate with the patient's physicians. We shouldn't be out here in the Wild West just treating patients without talking to their physicians, unless we absolutely have to in certain circumstances. It makes sense to involve them. And the physician's notes are much easier to obtain if we have that open communication with the physicians, correct?
It is. And again, it kind of comes back to that reasonable guy. I hate to agree with anything from the government. That's scary to me. But in this particular case, it makes sense. So, when you look at this, you got to remember that there has to be some consistency through the patient's record. The patient's sleepy and tired all the time. It's not like they're never sleepy and tired, and all of a sudden they have a sleep test and they're sleepy and tired. So again, you don't want to put words in patient's mouth, but in their mouth, but you do want to kind of coach them through this stuff, and you do that. But that's why Guy said it's so important to establish that communication with the physician. I'm here to tell you, Guy, I believe that the single most important thing that comes about from us treating Medicare patients is our acceptance into a very big part of the medical world. Mm-hmm. Physicians don't like most of us as dentists because we've kept some independence from having to do things this way that we're talking about. And when a dentist now starts to play that game and do that, I can't tell you, I don't think a week goes by, Guy, where we don't have a doctor call our office and go, man, it's so refreshing to find a dentist that will actually work with my Medicare patients and their insurance and their out of pocket, and that will communicate with me and do this. So now, guess what? That guy now refers me a patient every week or two. And, right. And 2 or 3 years later, I got like 20 or 30 doctors that do that now. So it just kind of builds and builds and builds on itself. And we haven't even talked about that. We don't even have a slide for that kind of intangible benefit from that.
Yeah, and it's very satisfying too. I mean, you help the patients, and now you've got a relationship with the physician. And I mean, we can do a whole nother webinar. Actually, I did do a whole nother webinar, a talk at our symposium about that last year. So a lot of good reasons to do this the right way. This is something, that I don't think we were doing it all the time. And, this is where, as we started working with more and more third-party billers, they made me realize, hey, we've got to have them sign a piece of paper. And it's really made sense to me when I looked at this, because my mother got oxygen a few years ago because she has emphysema, COPD, and they delivered it there, and she had to sign a piece of paper saying, I received the oxygen, right? Because it's durable medical equipment. It's the same thing here. We are the same as CPAP vendors. Unfortunately, that's what they consider us as. And so you think about it, we're handing them a piece of durable medical equipment. They just have to sign off on this. And a key thing that I learned a year or two ago that I was maybe a little more lackadaisical about it than I should have been, is they're kind of sticklers that proof of delivery has to be signed the day that you submit the claim. So we might have them sign that, and then we maybe bill this out 2 days later, 3 days later because we're busy. Bill it out the same day that they sign it. So when they're there that day, they got the device, and then the billable date, the date that we did it, it has to match up with them. So pretty easy to do. We just have this, this on the way out the door on the right before we deliver the device, we have them sign the proof of delivery. The ABN, mostly indicated, Rich, for the opting out people, but
we're actually recommending, Guy, that everybody use this all the time now. And if you think about this, what this is, if I'm a Medicare patient and I come in to see Guy, and Guy says, hey, Rich, you have sleep apnea. We're going to make you a dental sleep device for your sleep apnea. You know what? Medicare may not pay for all of this. So you might have to pay for some of it. So it's not unreasonable to protect me as the patient just to know about what I'm going to have to pay for this. Or in the case I've opted out, that Medicare's not going to pay for any of it.
And I tell you, this is going this way more in medicine in general. Yes. There's some legislation here in Florida to where you're going to have to post your fees on the website, to where they're wanting to be more transparent in medical fees. Which, I'm not big on regulation. We could go off on a tangent, which I won't let us do. But having been in the needing medical care, you don't have any idea what things are going to cost half the time. And so it's gravitating towards this, and this is Medicare's way of trying to protect the patient. All this is to protect the patient, to make sure that they're getting transparency and what the procedures they're doing, and that you're doing the procedure, and that they know what their estimated cost is going to be. So we could spend a fair amount of time on how you fill this out. If this isn't clear, then set up a consultation with one of our 4-pillar billing team or anybody at DS3, and just type in consultation and you have some questions about this, and we'll go through it. The things in red I have here are where you're going to fill in. So those are the blanks. So you're going to put E0486 because that's what we're doing. That doesn't change for any patients. And then we just recommend putting mandibular advancement device. And the reason it may not pay, it could be not deemed medically necessary. We may put down here at the bottom after this, same and similar could be a valid reason as well. And we're going to put the billable amount for the estimated cost. So whatever we're billing this out at for our patients, whatever our billable amount is. And then we usually just put procedure there as listed above, and then we define that procedure. So that's where we fill in these lines. But what Rich is talking about here is you have to have the patient decide. They have to select this. What we're doing here. I want to proceed as listed above, and I may have to pay now, or they check what is at the bottom when I think I don't want to have the procedure done at all. And if you say you want to do it, but you don't want to bill it to Medicare, you pick the middle slot. So the patient reads this, and typically it's option 1, and then they need to sign it. I went through it fairly quick, but like I said, we can get in the weeds on that form. It's kind of confusing. Was that good enough?
Good. Yeah, I think that's good.
Well, let's talk about the same and similar, because I want to make sure that we have time. This is kind of fresh news, and what this basically is at a high level is Medicare says, this is your money too, and we don't want to pay for a patient to have 2 treatments that are the same or similar. Is that pretty good paraphrase, Rich? Mm-hmm. So basically, they don't want you to pay for if we did CPAP, they don't want to pay for a CPAP and a BiPAP at the same time. Okay, and they don't want to pay for a CPAP and a dental device at the same time, because you're treating. You got to pick one. Here's what they're starting to say, and I'll say this is something that's just come around, and one of the reasons they're your third-party billers is they can help you with this. And this is Medicare only, and we're only seeing it in a couple regions I'm going to give to you in just a minute. But what we have to remember is oftentimes commercial insurance follows suit with this. So what are we finding out? This is what we're finding out, and I want to emphasize today's date, as Rich already said, June, 26th, 2018. This is going to change. It's not just might going to change. It's going to change. It's going to change in the next few weeks, few months, few years. This is going to change. So this is what we know today, that if a patient has been given a CPAP, okay, so they've already been given a CPAP and they billed Medicare for that CPAP, okay, then you've got to start undoing some stuff before Medicare. If you're in the regions that this affects, which I'm going to go over in just a minute, currently, you got to start undoing some stuff. Number one is you got to quit billing Medicare for the DME, no matter which one of these three categories you fall into. They've got to pick. They're going to go do a dental device now, so we got to quit billing Medicare for hoses, masks, and all that kind of stuff. And if the patient has gotten that and they're in their 90-day trial period, and let me kind of explain that for those of you who don't know, Medicare doesn't give the patient CPAP anymore. They give it to them for 90 days. They have to adhere to a level of compliance before they let them continue on. If they continue on, then they go into the next category, which is 90 or greater days. They were compliant. So if they're under 90 days and they say, I don't want to wear this thing, then all you have to do is you got to get them to return the CPAP, because they don't own it at that point. They're paying, they pay for, the Medicare pays over time for these, and they've got to get a receipt from the DME company saying they've returned it, and the DME company's got to say, we're not going to bill anymore. And then you can go ahead and make them a dental device. Did I miss anything on level one, Rich? Because this is kind of new.
Beautiful. So when we talk about DME, we're talking about durable medical equipment. We're talking about the CPAP. Okay, so when somebody gets a CPAP, just like Guy said, Medicare's just renting it at first, and as long as the patient's using it enough hours and enough days, then they'll go to the next phase where they'll rent a little longer before they actually pay for it. So I don't think this is, again, unreasonable, Guy. I miss the good old days where Medicare didn't know what the left hand didn't know what the right hand was doing. We could get CPAP on Monday and a dental device on Tuesday, but right. Again, those days are over. So I think you did good. What happens after 90 days?
So if it's greater than 90 days, and we have less than 5 years, we'll say, you might be eligible. But what's going to have to happen is the patient's going to have to return to CPAP, and if they're still in the rental period. Okay, now if they've already gone through the rental period, then they don't have to do that. They need to obtain that receipt. In all cases, as we've mentioned, they've got to quit billing for DME supplies. And then the attending physician's got to complete a PAP intolerance form and a prescription for the oral appliance. And what we're finding is it's likely going to get denied at first. And then you've got to provide relevant documentation of why this is reasonable and necessary, why a dental device, oral appliance therapy is reasonable. And so basically you appeal that, and then we're seeing patients getting coverage on this. So this is the area that in my office where I'm going to say, hey, these people may not have any coverage, and we're still going to try to file it. We're still going to try to fight it. But I would say this is certainly the gray area right now. If it's been over 5 years, then we're golden again. And again, that's just the same as if we were at a dental device, right? They're going to pay for a dental device every 5 years. So they've paid for the CPAP that's over 5 years. They're eligible for a new CPAP too, I would assume, or a dental device. But again, they've got to quit billing for the supplies. They've got to tell the DME person, hey, I'm getting a dental device, and you've got to quit billing for the supplies. So that's what we know today. I hope, Richard, when you say you think this is reasonable, I hope that they'll make exceptions if we document well that a patient needs both, because we do both on patients on a fair amount. Sometimes we do it at the same time, which is a combination therapy or dual therapy, rather, not combination therapy. And then sometimes patients won't take these when they travel, can't take them when they travel because they're overseas or something like that. And sometimes we make the dental devices for when they're traveling. And hopefully we'll stay tuned, but hopefully we'll find a way to document that well enough to where in those situations Medicare will see their way to paying for both, because they should. But right now, this is where we are, and so it's very new information just in the last few weeks or month or so. Did I miss anything on that, Rich, that you want to add?
I think you did a great job with that. So the bottom line on the dual or combination therapies is very, very difficult to get any insurance company to pay for both. You just do the best you can. We usually say, hey, you guys pick one. You know, keep getting CPAP and supplies, and then just pay me for the dental device, and I won't bill you for another 3 years. If it breaks, I'll take care of it. That's kind of how we deal with it, Guy, when we do that kind of stuff.
Yeah, and this virus has only taken effect in jurisdictions A and D so far, as far as we know, but I'm confident it'll infect the rest of the country here shortly. So right now we're only seeing it in these 2 jurisdictions. I haven't seen it in my office yet. Have you, Rich, had any patients been denied for something similar yet?
No, but we're actually already trying to implement all of
Right.
these things that you talked about, Guy. You know, and again, if you go back to in the beginning, Guy, where you were talking about, hey, what do we need for Medicare patients? You know, the CPAP intolerance affidavit, you know, the prescription, make sure it's medical necessary. It's not really that much different, you know, so the same and similar. We just are learning about this. We're trying to be on the cutting edge. This is another reason why you might want to use a third-party biller, you know, as you do this. And this makes sense.
Yeah, I think someone pointed out that one of my biggest weaknesses in life is that spelling, so I probably misspelled Nordium, but, you know, I think Lisa gave it to me, who's also from Kentucky.
I didn't see that.
And she misspelled it because I just cut and pasted it from her email. So I'm gonna take dual credit from the 2 Kentuckians who can't spell. But all right, well, I think that was great information. We're going to kind of wrap some of this up here with, you know, I think that was a lot of information, but none of this is hard. It's just following procedures, having the book there with the little forms in it, and just at a higher level, just remember who ordered the sleep study. That's important. Who made the diagnosis? That's important. Who writes the order for the prescription? We've gone through the primary care. And who decides on the medical necessity? If the best, what do you call it, the best MD? You know, we always say primary care, but I like whoever's in charge of this patient does all those things. You know, other than maybe the diagnosis with the sleep physician being involved, then you're going to be golden, you know. And if you work with them, it's going to be beneficial for you and your practice, because you're going to grow your practice. You're going to enjoy that relationship once you kind of get used to working with the physicians, and you're going to help the patients. Documentation is the key to this.
Write it down. If you don't, it didn't happen. Just that simple.
It is. It's just that.
And you got to remember, you know, SOAP notes with Medicare patients. So remember SOAP notes. You know, everything's subjective, objective assessment plan. So you got to do that. So what do you need to get paid with Medicare patients? Go all the way back to where we started. MD, face-to-face, they order the sleep study. Now, we have to have a diagnosis of sleep apnea, but not only do we have to have a diagnosis, remember for mild, we have to have a minimum number of 10 events, and we have to have documented at least 1 comorbidity. For moderate, we have to have a minimum of 30 events, but we don't have to document anything else. For severe, we have to document CPAP intolerance for whatever reason they don't want to do it. So then we get the authorization. You know, we have the patient sign the advanced beneficiary notice, and make sure we use a Medicare device. And now, just because we do all this, Guy, doesn't mean they're gonna you know, not deny the claim. You can still get claims denied. Somebody up here said, hey, I did this and I did this and I did this, and claim was denied. A lot of times we just resubmit the same stuff, or we'll call and we'll say, hey, what are we missing? We have everything that we need. We're following all the guidelines. You know, what are we missing? And it's not always your fault. Sometimes it's just an oversight by whoever's doing that. So again, cross your T's, dot your I's, get everything in order, and it's not that complicated.
Yeah, and again, I enjoy Medicare patients. When they come in, it's, you know, I think the thing that's really easy about it is we know the rules. I mean, they publish the rules. The rules are right here. We just went through the vast majority of what you need to know. So there's really no, you know, no gray areas with commercial insurance, especially if you're out of network. We don't have any idea what they're going to pay. We don't know without reading every one of their policies what their rules are and so forth. So I think getting in a practice of doing things this way is also a great idea, because as you do commercial insurances, if you adhere to the Medicare guidelines on all your patients, then you're going to do fine with them too, because it's rare, if ever, that they're more restrictive or require more information than Medicare does itself. So, I mean, I think that's a lot of information on Medicare. I think that's
that was good, Guy. You did it. You did a great job putting that PowerPoint together, man. You took something that I think is in a lot of ways very intimidating and very scary, and you kind of broke it down into nice little chunks for people to understand. So that was fantastic.
Well, I think we all did it, and I think, thanks for saying that, Rich. But that's what we do at DS3, and as you know, we for years worked on this to try to find a way to make this simple, because all these little moving parts are difficult. And we have a way of doing this in your office where you can have a dentist spend less than an hour to treat the patient from start to finish. It's utilizing your team. We will help train your team as well to be able to do this. And it can be very rewarding, because for less than an hour of your time, I mean, how many, let's do one of these a week. So you want to give an hour of your time, less than an hour a week, to make another $90,000? I mean,
I'll sign up for that, guy.
Yeah, it's absolutely no brainer. It really is. We can help you do that. That's what we do. And you could go to our website and look at our testimonials. We have hundreds of dentists throughout the country that use our services. And what we do is help you have a plan. We help you have a plan in dental sleep. And we can do that through our DS3 experience, and we can also do that through our courses. And Rich just taught one last weekend. We've got quite a few coming up towards the end of the summer and then the fall. You can see the dates here. These are hands-on 2-day courses, so they're all the information you need for all the steps of treatment. But in addition, you get a sleep test done on yourself or one of your team members. So I mean, I think it's just incredible to go through that experience yourself. And if you think you may have apnea, which, Rich, what was it? 61% of the people that came to our courses, I think we found, had apnea. Maybe that's why they came, to get the free sleep test. But you get that sleep test. You get to read it. You get consultation with it. And you get a dental device, too, a custom-made dental device from one of our partner labs. That in of it itself is worth near $1,000, with which we charge for you to come. It's $995, and that includes a team member for a 2-day course that's really highly focused on hands-on. And because you took the time to spend out the Tuesday evening with us, if you type in course, you can tell us which one you want to come to later, unless you know it right now. That'll secure you $200 off. So, I mean, certainly the sleep test alone and the device is worth $795 to come to hear one of us talk about dental sleep. I promise you'll enjoy it. It'll be worthwhile, and you and your team will get a lot out of it. If you want to get out of the cold, if that's where you live, then we have a great suggestion. Why don't you go to Clearwater Beach in February and stay at the Hilton? That's like fun. Well,
that was such a fun meeting. We've done it twice now, and it's sold out, the first 2 years. And, what a great lineup of speakers and topics, and everything we do is about how to help dentists succeed at this. So everything is very practical and clinical, and you and your staff will both get an awful lot out of this.
Yeah, and if you register now, you're going to save $100. It's $495 for the meeting. It's a 2-day meeting. As July 1st, it's going to go up $100. So get in early and save. It will sell out. We almost sold out last year. We sold out of a room, but we've expanded it a little bit next year. But I'm confident we're not going to have enough room for everybody. The rooms are $250 a night for the Hilton in February in Florida. Is an incredible deal. Those will certainly sell out. They've sold out the last 2 years. So if you want a room, get that early as well. I promise you'll love the meeting. It's the second biggest sleep meeting in the country, and we're proud of it. It's got a great reputation, and we hope to see you there. We hope to see you on this Tuesday, July 10th. I think Rich and I might be in the backgrounds listening, but we get the week off. But if you haven't heard Erin Elliott, she's a real practical dental sleep dentist. I promise you'll learn a lot of what you can do and not do to succeed at dental sleep. And our COO of Dental Sleep Solutions, Jason Tierney, will be emceeing, interviewing, whatever the right word there is. So I think that it'll be well worth your time. If you want to know more about what we do, type in consultation, and someone will just schedule time to talk to you, answer any of the questions that we didn't get to tonight, or give you even more detail and talk to you about how we can help you. It's not going to be a high pressure sales thing. We promise that. It'll be we're here to help you type conversation. So Jody or Brandy will get with you if you type that in. And if you want no more specific insurance, we'll get someone from the 4-pillar billing team. So look at that, Rich, 9 o'clock on the nose. Boom.
Good.
So let's see what do we, I'm looking, we have such a great help. All those of you who are putting in questions and getting these great answers, this is not Rich and I putting that information in there. It's our team. That's what we do. And it looks like they've done our job for us here, Rich. Is there any questions up here? Let me,
one thing I want to make clear, though, Guy, that came out in the questions, and Lisa, one of our top insurance lady here at 4-pillar, answered, was the question had to do with, do we have to balance bill the Medicare patient the difference? And the answer is no, you don't have to. But Lisa made a very good point, Guy, in saying, whatever you do, be consistent with Medicare patients. Don't charge one patient this much and the next patient this much and that. Just be consistent in how you bill and what you do, because that can be a red flag if you start getting all over the board with that kind of stuff.
Yeah, and Rich, I think with the mantra of the night's been, we should do this anyway. And I mean, if for your commercial insurance patients, you should be consistent as well. You need to have a system for cash patients, commercial patients, and Medicare, and they should be very similar and consistent across the board. You don't just look at what kind of car someone's driving and decide to base your fee based on that particular day. You need to be consistent in it. So
yeah, and consistent too, Guy, in the sense that I can choose, if little old lady comes in my office and I choose to participate with Medicare and she doesn't have secondary insurance, if I choose to waive her copay as part of that, and I document why I want to, right, and the reasons for that, because she's in financial hardship and this and that, I think that's okay. I don't think there's anything wrong with that, and I don't think there's anything illegal about that. You just have to be careful, about how you do all of that. So you just want to document. It's our obligation to try to collect that co-insurance and the co-payment. We are supposed to do that.
Yeah, I think Nancy's answering this question here. Let me throw my 2 cents in on that. Okay. I mean, and everybody, thank you for attending too. Welcome to stay on. We're going to answer these questions. You will get your CE, and please talk to us at DS3 and help you to do more dental sleep. If someone's a Medicare patient and they have a financial hardship and they can't pay us or for whatever reason, so what are we going to do? We're going to accept assignment of benefits, right? Right? That's the first thing you're going to do. Yes. So now the Medicare check's going to come to me, and in most cases, they have supplemental insurance is going to come to me. So this, for the most part, with Medicare, is a non-issue anyway. In the rare case that person doesn't have a supplemental insurance, okay, I will bill them for their 20%. But if they can't afford to pay, and we send them 2 or 3 statements and we document that they can't afford to pay, then we write off that balance. There's going to be, every physician in the country is going to be in jail if you go to jail for doing that, because they've all done it. Okay, we will have no physicians, and we'll have not enough jails because everyone's going to go to jail. It's common sense. We're doing the right things. We're trying to collect the money. If they can't pay us, we're not going to show up their house with the dental repo man and take their dental device from them. Are we? No, we're going to write the balance off because they can't afford to pay. So let's use some common sense here. I don't know that the answer where we says you have to collect it. Well, you have to try to collect it, and if they can't afford to pay it, then you can write it off all day long, and you can do that with commercial insurances as well. It happens every day, every hour, every minute across the country in the medical world. Just use your common sense. Don't. If it doesn't feel right, then don't do it.
Right.
But in most cases, if you
give it the old gut check.
gut check, right? So yeah, so and maybe give it the gut check, but also think about if this is medicine, not dentistry. We do have some biases or preconceived. What's the right word when you've been raised a certain way? But because the dental world's been taught a little bit differently, we look at things a little differently as well. So and this is all great stuff for conversations. We like to be open about it. You can help patients, help them with their airways, make a lot of money doing this, get paid a fair amount from the insurance, collect from the patients who can afford to pay in, even the ones that can't, we can help to the extent that they can help afford to pay us. And it's just it's, at the end of the day, you feel really great about what you're doing. So I think, did that answer all of them then, Rich?
It sounds like Nancy's in a tough part of town, man. Her patients don't want to pay. No, I'm kidding. I'm kidding, Nancy. None of our patients want to pay. Again, you got to be consistent. If can you write it off from the get-go? You can, but you got to document that. I think most people would say reasonable attempt to collect the patient's copay and insurance. That's where guy said we send them a couple of statements, we do this and that. So I think one case here or there, yeah, you can do that, but again, you got to be reasonable about that stuff and make a reasonable attempt.
Yeah, and you got to document it. And
I would document it. I would also add, Guy, maybe too, that I think as we get better doing what we do in the clinic where we see patients, we're much more serious about treating sleep apnea.
Yeah. Yeah, and if you
can't
get patients,
I had a guy today. I did a consult today, and he goes. So I had a guy today, and it was just, Can you hear me?
You're kind of cutting out. I don't know if it's just me. I can't.
All right, you talk for a second.
Yeah, you're cutting out. I would just say, if you're having trouble getting patients to say yes to treatment, how you handle the money is number one. Having a system for that. How you discuss it with the patients and how you present it to them and how much you believe in what you're doing and how well your team's trained. All these things come into helping you get patients to say yes to treatment. It's not easy. No one's saying it's always easy, but it's certainly doable, and that's why we exist. So, and we're happy to carry on that conversation further with it. I think Rich is like circling on the dark side of the moon now or something. I can see his face, but I can't hear a word he's saying. I hope you land safely over there in what's the lake on the moon there? In Tranquility Bay, Rich. But I think that's a good cue for us to quit the webinar now. So thank you, everybody. If you have more questions, just contact us here at DS3. Type in consult, and then don't forget to tune in a few weeks to hear Jason and Dr. Aaron Elliott. And I'm going to end that. And I can see you, Rich. Bye. I'll talk to you later, buddy. All right. Good night, everyone. God.